introduction, and again I'd like to also say congratulations to KOLKATA for organising a fantastic AIOS meeting that I was lucky enough to come to last year in India as well. So I'm going to be talking about fine-tuning cataract surgery with a laser refractive surgical procedure, and I'll show you why I think this is important for all of us to consider, especially when we look at the realm of cataract surgery. These are my financial disclosures as well. So many of you will know that last year was a very historic year. It was the 75th anniversary since the first IOL was implanted at St. Thomas's Hospital, where I was lucky enough to be a clinical and medical student. And interestingly, if you look at how Ridley's results following the implantation of the first lens, the first lens had a residual refractive error of about 20 diopters because there was a miscalculation in measuring the refractive index of the PMA of the IOL. But actually, if you look at the next series of lenses, the majority of the patients were actually within a diopter, and amazingly, one patient actually got within 6/6 vision, corrected with only about 0.025 diopter of residual refractive error. So, and if you look at the way the surgery was performed with the old long graphene knife and a huge incision, it's amazing that these results were basically achieved. Now, over the next 12 years, over 1,000 Ridley implants were implanted, and over the years, we've seen improvements with respect to the accuracy of our biometry errors when we're doing cataract surgery. And there have been audits from the UK in 1980s, looking at outcomes. Norby basically published a series in 2008. The majority of surgeons, almost about 74%, are getting in between about half a diopter of refractive error, and single formula optimization can basically increase this to about 92%. Now, Ridley's first report of the first IOL was published in St. Thomas's Hospital reports, as you can see a copy over here on the left-hand side. What we've seen over the last really decade has been an evolution of cataract surgery from the times of Ridley, where it was considered a therapeutic procedure, to really what we transitioned from a therapeutic to a therapeutic refractive, and really now to modern-day cataract surgery, where we consider this a refractive procedure. And the reason why this has happened is really because of this list on the right-hand side. You see this from our paper published in The Lancet in 2017, where you can see the actual rates of complication, both intraoperative, early postoperative, and late postoperative complications from modern-day cataract surgery are actually very low. I mean, because the complication rates have been driven down, we can think of this as much more of a refractive procedure now than a therapeutic procedure as we did in the past. Now, we know the accuracy of cataract surgery is dependent on several things. Of course, the postoperative effective lens position, measurements of the keratometry, axial length measurements are basically all taken into account in many of these newer generation formulas. And if you look at the newer generation formulas over here, you can see on the right-hand side, they actually all do pretty well if you look at the axial length values in the medium to medium-long range itself. When you look at the extremes, you can look at the MAE, actually is not so good there. You look at larger MAE, standard deviations with the shorter lenses, and also basically in the longer lenses as well. If we look at this in a little bit more detail, and here you can see almost 12 formulae, modern-day formulas itself, and on the y-axis you will see increases in accuracy from 0.25 to 0.5 to 0.75 one diopter, and on the x-axis you'll see a percentage increase. Now, if you look at the 100% bar, which is where the arrow is where I'm pointing to, you'll see actually there's no IOL formula that will give you 100% accuracy within 0.25 of a diopter that you're basically aiming for certain equipment. And actually you'll see none at basically even at 0.5 of a diopter over here itself. You'll see most of the formulae will run between about maybe 65-70% all the way basically up to 80%. And this is really most of the formulae that are available in literature. So what that tells you is that even if you're doing modern refractive cataract surgery with premium lenses as well, you've got to get situations where you're going to get a little bit of an error in your outcome that you may need to do something else to basically touch up the effect. Of course, modern-day laser-based treatments now that we see with our corneal refractive surgery can be in three different forms. On the left-hand side, you see advanced surface ablation. Of course, LASIK now has been around for over 25 years, and of course, more recently, over about the last maybe 10 to 15 years, now we have lenticle procedures. SMILE was the first-generation lenticle procedure with over 10 million procedures performed now, and now we have 5 KNX lenticle procedures that can help us to fine-tune our result following our cataract surgical procedure. So let's look at some examples of where we use different procedures and why I choose different procedures for different settings. Here you'll see a patient, a 61-year-old Chinese Singaporean gentleman who underwent uncomplicated phakic emulsification by one of our residents. He wanted monovision correction, right eye, achieved a good visual acuity outcome, unaided, with normal topography. Left eye, he underwent basically monofocal cataract surgery. They were aiming for basically minus 1.25, but the patient ended up closer to basically half a doctor. His unaided visual acuity was 6.9. He was unhappy because he was unable to read. His vision was only N10 at 45 and also basically 55 centimeters as well. So what are our options basically over here? Now, obviously, if it's early, you may be considered to do a lens exchange, but because you're looking at about 0.75 a doctor accuracy correction, of course, we can touch this up with a laser-based procedure. And because you have a monofocal lens, any of the three prior procedures that I've shown you can be AC applicable. So we can do LASIK, we can do SMILE, we can do advanced surface ablation. The procedure of choice that I prefer to do in these situations is basically using a low volume or low intraocular pressure rise femtosecond laser system itself. In this situation, we chose basically to do LASIK. The reason why, you can see on the right-hand side, I prefer to use the Vision Max. This is using the 800 system, is because the intraocular pressure rise with the Vision Max is much lower compared to other laser systems. And obviously with the phaco incision, even though it has healed and was more than 3 months post-operatively, there's always a chance that with the raised pressure inside the anterior chamber, the wound could actually rupture itself. So I did a 100 micron LASIK flap. I brought him down to about -1 to about half a Doppler shift. That was N5 unaided for 40 centimeters and also 55 centimeters, and 615 unaided for distance, so he's quite happy with his visual outcome. So this is great for when you're basically putting monofocal lenses in, but of course in more complex procedures, you may need to basically think about doing something else. And the reason why is because you need to think about controlling the effect of aberrations as well as actually choosing the low order aberration at the same time. If you look at the outcomes from standard lenticle procedures, and this is using first generation 5, they're very good with respect to unaided visual acuity outcomes, but you see there is a variability with respect to variation in centration and torsional control. And the reason why this happens is because even though you do induce less spherical aberration with any lenticle procedure, you can induce more coma. And this is really linked to the first generation SMILE procedure. In the future, this may change, but we have newer procedures such as Clear, Silk from basically J&J, SmartSight, and also the Vision Max 800, where you can control the torsion and the centration of the lenticle procedure itself. This may allow you to get a bit more predictable outcome in the patients having had previous cataract surgery with respect to controlling the spherical aberration and the vertical coma. But this is still quite new, and until we have basically perfect control on centration or torsion, I think the answer basically trying to treat patients with slightly more spherical aberration is to use a excimer laser-based treatment. I'll show you examples of basically why we basically do this. And here you can see how in the very near future we'll have full automated centration and torsion control by linking the femtosecond lasers to tomographers. As you can see this example on the left-hand side with the Galileo G6, and on the right-hand side here with the Cyrus from Schwinn, and also the Pentacam for the Elite system as well. Now, excimer-based systems allow us to do something slightly different. And the reason why is because not only has the delivery system changed over the years, the algorithm with respect to how we actually deliver the excimer ablation has also changed. And we can do many patterns, such as wavefront optimized, wavefront guided, and topography guided platforms as well. And the three most commonly used lasers in this system are either the Zeiss, either the MEL80 or MEL90, the Alcor system, EX500 or the EX400, and obviously the Schwinn system as well, that allows you to basically to do this. And I'll go through this in a little bit more detail. The key things about all of these laser systems is that not only do you have to have very good, fine, accurate excimer ablation profiles, you need very, very good trackers to actually lay down the pattern or the unusual pattern that you're going to basically lay down in the cornea, as opposed to standard wavefront optimized ablations. So this is just an example to give you an idea of basically the ablation pattern. This is a typical spherical aberration, basically control pattern with a topolizer. This is what happens if you basically try to treat this patient with a spherical equipment using a wavefront optimized system itself. But this is the pattern of ablation that you basically want to treat when you use topography-guided treatment. And you can see the topography-guided treatment that the lasers basically put down matches exactly the topolizer treatment itself, while the wavefront will give you an uneven, if you use a wavefront optimized system, it will give you an uneven ablation profile. this is why these systems itself, using a topography-guided excimer laser ablation is superior than using basically a waveform optimized system. So I'll just show you two examples here where we basically use this to our advantage. This is a 69-year-old Singaporean Indian gentleman who had a bilateral restored lenses putting, I think, over 15 or 20 years ago by one of my colleagues, who was complaining of dysphotopsia, and he came to see me and said that dysphotopsia has got worse over the last few years. You can see his refraction over here in the left eye. And I said to him, well, look, you know, a lot of your dysphotopsia has come from basically this multifocal diffractive lens that you have inside the eye. You can see the rings there through his pupil. But he said, you know, it wasn't too bad, but when I refracted him and I put this refraction in there, he said that actually the dysphotopsia gets better, he doesn't get so much distortion. So clearly the one doctor astigmatism was pushing his basic dysphotopsia. This is basically his tomography on the left-hand side over here, so you can see quite an even surface on the cornea and basically slightly higher posterior flow. You will see over here his aberration control is quite normal. So here I advise him that we're going to go for an advanced surface ablation using a topography-guided profile, using a trans-epi approach, and I'll show you basically what we did. This is another patient, 71-year-old Chinese gentleman, previous history of both eyes PRK done in 1992 for -4, -2 SIL. Right eye dominant vision, so the right eye I put a spherical aberration neutral lens to reduce the spherical aberration down, and the left eye I used an ICA to help him with basically intermediate and near vision. If you look at his unaided visual acuity outcome, on the right eye not too bad, 612 + 1, left eye unaided he's 612, but he reads N5 for 40 and 63 centimeters, so you're using the ICA to help him for intermediate and near vision. If you look at his refraction and his left eye is -1, that's the sweet spot for the ICA lens. His right eye is about -0.5. It was okay, but he said that, you know, John, can you increase my improvement in vision, in my distance vision in the right eye? If we look at his basic tomography on the right-hand side over here, you'll see that he's got a little bit of irregularity on the surface. You can see a little bow tie on the surface over here on the anterior flow. If you look at his aberrations, obviously from PRK that were done over 25 years ago, there's a lot of spherical aberration on his right eye. And if you look on his left eye, it just shows you how good the ICA lens is. You can see his spherical aberration is 1.1 and his vertical coma is 1.4, yet he gets basically N5 for intermediate and near vision. And I use this as a standard lens in all my post-refractive patients, give them intermediate and near vision. So this is the planning basically for these cases. So this is the topologizer profile of the first case. This is basically what happens if you just program the high order aberrations, just taking it from the topography guided basically software. Here we're going to add in the high order and the lower order aberration for the first case. So this is basically the ultimate profile that will be basically fired upon the laser itself. And you can see basically in the high order aberration corrections, we're going to basically try to control or maybe reduce some of the spherical aberration of this individual patient. Now, one of the key things basically when you're doing topography guided treatments is not only to ensure that the patients have excellent centration, but you must be able to control the pupil size. Here you'll see examples of acquisitions of basically different topography profiles of the actual same patient itself, and you will see that as I basically vary, as the pupil size vary, you can see the shape of the tomography that's basically being picked up over here from the ablation pattern will actually change. It's very important that you pick pupil sizes that are going to match the pupil when the patient's underneath the excimer laser. Otherwise, what's going to happen is you're going to get a difference in what the ablation profile is that is laid down compared to basically what you captured on the pupil. So ideally, you need to make sure your diagnostic acquisition of the pupil itself is similar to the size of the pupil when you actually basically fire the excimer laser. This is super important, especially when you're trying to control spherical aberration. The second thing, of course, is the centration, and your lasers now should be able to track you to give you an idea of basically what the centration profile is as well. Okay, so how do our patients do? So if you look at the first patient, this is the eye basically following the spherical aberration treatment. You'll see over here he did pretty well. Preoperatively, even though he has that multifocal lens in, the spherical aberration was 0.234. We didn't induce any spherical aberration or hardly any spherical aberration with the excimer-based treatment. You got good visual acuity for distance, it improved his intermediate, and it basically improved his near vision as well. And you can see on the 3D scan over here above how we flattened basically the topography profile to reduce the variation in the surface. But the most important thing here is you haven't increased the spherical aberration by doing the excimer ablation treatment. And of course, in somebody that has a multifocal lens and diffractive multifocal, this can be very advantageous in the long term. The second patient that basically had the ICA in his left eye, you can see over here again, preoperatively spherical aberration was 1 from that PRK that was done over 20 years ago, and here we're able to reduce the spherical aberration down to 0.78 and also basically improve his basically surface profile. So now we've got him 6.6 in his right eye, he's 6.12 in his left eye, unable for distance, but N5 for intermediate, N5 for basically net. So it works very well to basically doing a touching up of the profile itself without actually, and in this example over here, we're actually able to reduce the spherical aberration as well and try to improve, take him out of the toxic range as well. So in conclusion, IOL accuracy has advanced significantly over the last 75 years. We have all these modern generation formulas, but even with the modern generation formulas, with AI technology, there is still an error rate, and it's important to understand that, especially if you're doing premium IOL surgery as well. And patients, and this is higher when we see patients outside the normal range with respect to their axial lens as well. The use of modern-day laser corneal therapeutic surgery in the form of topography-guided treatment, or even basically based with femto, so wavefront if it's a monofocal lens, can save the day and can fine-tune the refractive outcome in our patients. The choice of the procedure is basically dependent on the complexity of the IOL that is basically implanted, and if there's a previous history of prior laser vision correction. Certainly, if it's basically a multifocality lens and basically putting in, you must basically consider doing a topography-guided treatment to try to balance some of the high word aberration, or at least do not induce higher word aberration during your basically laser ablation treatment as well. So I'd like to thank you for your attention and the kind invitation to partake in this symposium. Thank you.
Thank you, Jod. I think that was a very illuminative talk. Illuminative because you showed us that despite the fact that patients have had refractive procedures with PRK, with ASEC, you can still put multifocal IOLs, and even if they have residual errors or residual aberrations, you can still go ahead and do excimer laser procedure or a smile thereafter. So, are there any questions from the panel or from the house?
Thank you. That was a really illuminative talk. If I can ask you, when is the right time to fine-tune, the patient?
So yeah, that's a very good question. So what I would tell people, so most of the times, well, by the time I've seen the patients, the lenses have been in for quite some time, so they've been in for like normally a year or longer itself. So then of course IOL exchanges then become much more risky in that situation. So what I would basically tell people, I need to get a couple of readings. It's a consistency in the reading. So I need at least 2 readings, minimum time period of 6 months apart before I'd even consider to do the topography guided treatment. And even then, the pictures that I showed you of the topography-guided diagnostic acquisition actually is taken only 3 days before I actually do the treatment on the individual patient itself. So what I would say is that I certainly wouldn't do it early. If the patient only had surgery within 1-3 months or maybe 6 months from surgery, I'd think about doing an IOL exchange if they're really basically unhappy or there's some sort of problem. But a lot of these kind of patients have had surgery, like I showed you, like the guy who had the restore lens, he had to put it in 10-15 years ago itself. So even then, I didn't do any laser from the first time he came to see me with a problem. I waited until he has, I'm convinced he has refractive stability before doing the procedure. So 2 readings, at least 6 months apart, on stable tomography and stable refractions.
Very nice talk, Dr. Jodbir, sir. While you talked about the flattening or decreasing the spherical aberration after the cataract surgery, if there was, is there any way to counter other higher order aberration like coma and trefoil, which also sometimes really makes the patient very unhappy and dissatisfied?
Yeah, absolutely. So I focused on the spherical aberration because that was the abnormal thing here as well. But the topography guided treatment will treat the vertical coma as well. So it will treat vertical coma and spherical aberration itself. In this example I showed you here, I just basically focused on the spherical aberration because with the multifocal lens, I didn't want to induce higher spherical aberrations. But with the topography guided profile, you will treat the vertical coma as well.
I'd like to ask you that how often do you practice monovision in your patients, in patients where you can't put any multifocal because maybe there are issues for that? And how do you actually decide that what should be the difference be it 0.5, 1 diopter, 1.5 diopter monovision in your patients?
Yeah. So I used to do, before ICA came around, in my post-refractive surgical patients, I used to do monovision. Okay. And what I would do in these patients is, the first thing I do, I'd send them for tomography to have a look at the spherical aberration, because you have to realize that a lot of these patients had LASIK done a long time ago, or PRK a long time ago, and the older excimer lasers are not as good as the new ones that we all use these days. So a lot of these people actually have very toxic levels of spherical aberration. Now sometimes, if you have somebody with a higher spherical aberration, it can actually increase your depth of focus, so it can help you with the near focusing element. So in that situation, you may only have to basically, in the non-dominant eye, you may only have to put a 1.25 difference compared to the dominant eye, where you're basically correcting for distance vision, because they can use their spherical aberration to help them with a little bit of depth of focus as well, to help them with the near focus vision. If they have lower levels of spherical aberration, then you may want to increase the amount of myopia to maybe minus 1.5 to basically help them with the focus. Since I've been using the IC8 now for almost 7 years now, and I know recently it got FDA approved, so since then, in about the last 7 or 8 years, all my post-refractive surgical patients, whether it's RK, whether it's LASIK, whether it's SMILE, whether it's PRK or surface ablation, they all get an ICA in the non-dominant eye. Because the ICA has the advantage because of the pinhole effect, it will neutralize the vertical coma and the high order aberrations that I showed you in that example. But their distance vision is much better than you'd actually normally expect. And that's my first choice in the non-dominant eye. In the dominant eye, what I normally do is, if it's a myopic laser ablation, then I'll use a spherical aberrating negative lens, such as a ZC Booth, for example. If it's a hyperopic ablation, then I'll use a positive spherical aberration lens, such as an SA60, for example.
Thank you so much. John, any question? Anybody would want to ask?
Dr. Mehta,
Yes.
you just commented about this pupil size before
Yes.
you take the paper to the. So any clinical instruction for really taking care about what pupil size we should really go about?
Yeah, that's a good question. So with the ICA, I mean, the main thing is that the pupil, if the scotopic pupil certainly goes on, the mass there is about 3.6. If the scotopic pupil goes beyond that area itself, then they're often at night time, they will get some image distortion, or they do get some image glare around that. What I've done, I have a few people who basically have had that, and then I give them a bit of alpha-GAN, and I try to get them to try that at night time itself, and that seems to do the trick. I typically see that if it's a slightly younger patient who is having cataract surgery. So when I mean younger, I'm talking about people in their early 50s, as opposed to some of the older people where you don't get so much pupil dilatation anyway, and they don't normally dilate around that thing. But I do ask them about that, and that's one thing that you do need to be a little bit careful about with the pupil, because if it's a large scotopic pupil that goes beyond the mask, then they definitely get, especially when they look at a light source like a street light, then they may get little bits of distortion.
Thank you.
Okay, thank you, John. Thank you for being with us today, and looking forward to seeing you in Delhi at APU. Thank you.
Thank you.